Nice and short. Yeah. So curiously, Tom, have you been traveling to talk much the past year, or have you been pretty well locked down?
I've done a lot of presentations this past year, mostly from this room right where I'm sitting now, via Zoom. And occasionally I'll get in the office still. It's fairly safe in the office because everyone else is still at home, so I can go in the office without too much trouble. But yeah, I've presented to a lot of groups, which is always great, and I love doing it, but mostly right from here. Okay. And I'm a little jealous that we're in the middle of a pandemic, because I would love to meet all of you at the Columbia Club and have lunch and do that, but unfortunately, it's not possible right now. So maybe in the future.
We would love to meet you too in the Columbia Club. We would love that.
We won't even make you sing for your supper. You can be our guest.
Well, I'll sing and play guitar. How's that?
There you go.
Do a song and dance.
I'll join you.
All right.
I mean, if you're ever going to write a song on epidemiology, then now's the time to do it, right?
Well, it's funny you mentioned that, because I started writing one as a parody to Johnny Cash's Folsom Prison Blues, and I haven't finished it yet. Haven't had time. But yeah.
Well,
maybe
Roger
someday.
Cummings would be our member to collaborate with. So Roger, if you have any ideas.
Okay.
That'll work.
And Tom, I want you to notice Tracy and Burge is on the call.
Is she? Oh, there she is. Hey, Tracy, how are you?
This is my daughter.
I'm good.
Yeah, I remember Tracy, and I hear that you're finishing your doctorate.
Done with coursework, so I'll probably log off there around 12:30. I have another meeting I have to be at for work. So
Great. Well, I'm glad you could join us at least for a little bit.
yeah.
Although, Tracy, I think you, and maybe your dad mentioned this, is you went to IU Bloomington for your doctorate?
No, I did it up here. So
the problem with being out of the office.
yeah. Dr. Zhang is right now. He's sort of in charge, but I have to work on committee members soon. So I may reach out to you.
Okay.
So Mary Marsh, we had a great time at the Pacers home opener last night.
I was just going to ask you how comfortable you felt with all the protocols and everything they had there.
Well, I look for more of the Steele family on the Jumbotron ratio of how little people are in the stadium. So Lamita and I got on. There were, let's see, nobody, 10 seats either direction. So yeah, if the stadium was at 10% capacity, you have to walk about a half mile to get a beer. So I haven't had that much exercise in 11 months since we shut down. But no, we saw former member Chris Bush, who is celebrating his birthday of his 1-year-old. But no, we felt very, very safe. Thanks to you, we're going Friday to see Aaron Gordon and the Magic, which would be fun. It's shame to see how some of these trades have panned out and some of the injuries we have. But safety-wise, it's similar to the Colts, where there's no traffic going in or out, and you're so far spread out with people during the game. I mean, as long as you're comfortable wearing your mask for 2.5 hours and taking a sip and putting your mask up and taking a sip and you're taking a bite of dinner and putting your mask up, I really find it enjoyable. I mean, I would have rather won, but.
Good. Well, Chris Bush is the one that was able to get our front row tickets, even though they're in a different section. So I was grateful to him for taking care of that.
So you and John went to the game last night?
No, Eric did.
Oh, okay.
Well, everything's really streamlined, where you take a health exam before you enter, you know, I don't have COVID. I haven't been exposed to anybody with COVID, and I don't have these symptoms. And everything is paperless. Well, for us, you know, so the tickets are on your phone. Single serve, like when you're walking through the metal detectors, single service little baskets. So you put your phone in there, they throw it away, next basket, etc. But no, Chris was telling me they're renovating the whole stadium. They're going to start a 3-year process to really gut Bankers Life. I can't believe it's already 20 years old.
Some of that work actually got accelerated because of the delay in the season. So they've got quite a bit done already.
No, beautiful. All right, so we'll go ahead and get started. Please use the mute button, the bottom left button that looks like a microphone, or the space bar will turn mute on and off. Please stay muted during the meeting. If you'd like to talk, unmute yourself, then turn it back off when you're finished. We will be reviewing our bylaws next Thursday, January 28th. Make sure you tune in. Please consider making a donation to the club in lieu of paying for lunch. Any amount would be appreciated. We will be meeting virtually for all of February now, and we'll reevaluate at our next board meeting for the coming months as the statistics get more and more depressing. There's no reason to rush back into anything. The nominating committee is seeking officer candidates for board positions and president-elect for 2020 to 2021. Club year starting October 1st. If you're interested, please email Taylor or Tina. I am going to turn it over to Mrs. Nancy Ulrichs, who will give us a little insight into what being on the board looks like.
Thank you, President Eric. I think most of you know me. I've been a member since 1992. I'm Nancy Ulrichs, and I'm serving my 3rd term on the board, which is a little scary, but I've been doing it every decade I serve. And my time commitment is really very manageable. And so I would encourage any of you who are thinking about it, please do. You know, originally I saw serving on the board as a way to really get to know Indianapolis, really get to know the members, and acquire some business skills. And I was absolutely right. All 3 of those things happened. But this time, my 3rd time on the board, I know the people, I know the committees, and I still serve on a few of the committees. But this time it's different. And this time I'm trying to benefit the club, to have it go the other way. And while I'm still gaining positive experiences and friendships through the club, this is my time to give back and to the club who's meant so much to me. So I hope some of you out there will consider running for board member for the club. And I think you'll like it a lot. And if you have specific questions, feel free to contact me. Thank you.
Thank you very much, Nancy. I will turn it over to Miss Karen Burns, who will give us a bell ringing update.
Thank you, President Eric. So I sent out an email to everyone. I think everyone knows that we are going to pass the kettle to Rotary. I think everyone here also knows that my personal goal has been for Rotary to try to get competitive enough that they would really put their energies towards raising that money. I think they could do more, and I know that I would like to see them do more. And I know that our capabilities and capacities are much deeper than what was reflected in those totals, because of a lot of turnover of the Salvation Army staff. They didn't count the generous donations that our members made in the kettle. And so what we showed is our kettle collection was $2,500. They're showing $4,000 from Rotary, which is actually higher than what they've done in the past. I felt like, honestly, I do like to win. You guys know I like to win. However, I like the Army to win. And they're going back and looking at the contribution and the support that Kiwanis actually did put forward to the Salvation Army. And as you know, between that $10,000 commitment to Angel Tree, plus the generous donations of our members, I think we're going to see a pretty significant number. I decided to rise above the competition and not make it a deal, because frankly, I've had enough contested election to last a lifetime. So my goal is to grab that damn kettle back next year. And I'm looking for each of you to be part of that effort, because again, I'm not competitive, but what can I say? I want to thank all of you for your generosity and for what you did for the Army, because it really is about helping our neighbors and making sure that those who are in need are provided with life-saving services. We provided people a lifeline this year, and we made Christmas for Hoosiers possible who would not have been able to do it without Kiwanis. So I thank you all for your generosity and your community spirit. Let me throw it back to our Salvation Army representative. I'm giving you a moment of warning, Duke Haddad, for any comments you would like to make about Kiwanis and the Salvation Army. And it is okay to praise us lavishly.
Well, I will praise you lavishly, Karen, and I'll praise the club. I mean, with their involvement with Angel Tree, and certainly some involvement with Radiothon, and a lot of involvement with kettles. I mean, in my 9 years with the Salvation Army, this has been a stellar Christmas. With COVID and the pandemic, we need the funds, we need the involvement, and I want to lavishly praise the club. So many people stepped up to do so many things beyond the kettle, and it was never unnoticed, but I also appreciate your comments. Myself, we went through staffing changes this year and changes of responsibilities, and so that led to the situation that we're currently in. But again, as you said, we're doing an audit of things that we're doing. Bottom line is it's all good. Everybody wins. I know the first 3 years I was here, as I said before, Rotary won. The last 5 years, our club won. This year, you, as I said, rose above the fray, and with Rotary winning, we're going to look at some things for next year and some clarification. Bottom line is it's all good. Everybody wins. And again, I can't thank our club enough to give the $9,000 donation for Angel Tree on top of everything else they do with the kettle timing that they got involved with. And so, yes, I want to praise everybody lavishly because you deserve it. I want to thank Karen and congratulate her on her award that she won from Kiwanis, because we need, and God rest Joe, who, as you said, I think the last meeting, his memory lives on. His dollar bills live on, his just passion for kettles and to try to raise the money. We went into the Christmas season not knowing what was going on. And frankly, we projected a 50% drop in kettles across the board, not only locally, but nationally. We were pleasantly surprised. Several of our cores surpassed goal. Eagle Creek did not. But overall, we were amazed at that progress. And the other point is the challenge gifts. We used challenge gifts to our advantage this year in a huge way. In fact, it was over $180,000 generated in additional challenge gifts to make up shortfalls at the kettle. So a lot of things were employed that we're looking at, we're analyzing, and we're going to have, as I said, a more comprehensive game plan for next year. So thank you.
Thank you. And again, we did and do continue to miss our biggest cheerleader, Joe Marbaugh, and his presence and lack of presence was definitely felt. I think he was there with us in spirit, but we sure missed that special brand of enthusiasm that Joe brought to everything. So thank you all very much.
So for our new members, if anybody would like a committee to serve on around the holidays, Karen Burns can always use help organizing the kettle fundraiser. And then Joe Marbaugh, who some of you may not have met, was a wholly unique individual who passed away early 2020. He was a big advocate of Interclub. Jay Brill has taken over that committee. If anybody wants to work on kind of public outreach, bringing regional Kiwanis clubs together, I've learned a lot from doing some of the regional conventions. Again, Jay Brill for Interclub, Karen Burns for the Kettle, and now I'll turn it over to Diane Nichols, who will give us an update on Mr. Bill Perkins.
Thank you, Eric. Well, I think we have some bad news for everybody. They have called for end of life arrangements for Bill. He is still at Westminster. He contracted COVID and then went into pneumonia. So at this moment, they're making preparations, and he, of course, is due. I think he's going to pass on sometime, pretty soon. So his family has asked for prayer, and if I ask for your prayers as well for him, that he will go transition into eternity quickly and easily. So if you just pray for him, there's a lot of people in the club he loved and talked with. They are planning a virtual and an in-person. Right now, at least his family is planning something at Faith Presbyterian Church. Not everybody, of course, is going to be able to get in. They only allow 60 people. So there's a possibility of a reception. So as soon as I have details of everything, I will let you know. But thank you for giving me this time. I appreciate it. Appreciate your prayers.
All right, certainly, Diane. Yeah, he and his family will be in our prayers. I'll turn it over to Mrs. Nancy Ulrichs, who will introduce today's speaker, Dr. Thomas Duszynski, IU Director of Epidemiology Education, talking about COVID-19.
Okay. Well, some of you may have seen the last issue of the IBJ, and our speaker was quoted in it. And I think we're really lucky to have him here today. He has been speaking up a storm, he said, more than 80 times. So I'm glad we were on the list. Thomas Duszynski has worked in public health for more than 20 years and started his career as an environmental inspector for a local health department. He worked for several local health departments, including serving as environmental supervisor, overseeing a wastewater division, environmental program, and water quality laboratory. He served as a field epidemiologist for the state, Indiana State Department of Health, and in August 2005 was named director of the field epidemiology program. In 2010, he was promoted to Director of Investigation and Surveillance. He has also served since 2007 as the team lead for the Leadership at All Levels course and as co-author and teacher of the program. He holds a Bachelor of Science degree in biology from St. Meinrad College and a Master's of Public Health and Epidemiology from Indiana University School of Medicine. He was a licensed registered environmental health specialist in Indiana and recent graduate of the National Public Health Leadership Institute. Tom was also named to Delta Omega, National Honor Society for Public Health in 2011, and served as the Indiana State Department of Health Agency Incident Commander in Emergencies. Currently, he's a lecturer, PhD candidate, and Director of Epidemiological Education for the IU Richard M. Fairbanks School of Public Health at IUPUI. Please welcome our speaker, Tom Duszynski.
Thank you, everybody, and thank you for the opportunity to speak with you today. I really appreciate these moments because this is such an important topic, and I always enjoy working with the public on communicating good information and having a good message around this. So I'm going to share my screen and we'll talk about the impact of COVID-19 pandemic from a public health perspective. And certainly as we move about, if you do have a question, please don't hesitate to interrupt me. I'll be happy to try and answer all the questions that you may have around this disease. When we think about what a pandemic is, we really have to define it, right? There have been more than 40 new diseases that have affected humanity since the 1970s, and not all of them turn into pandemics. It's because you need certain criteria. The first is you need a novel pathogen, right? You need a new disease. And it's got to be something that we have no immunity to, right? So if it's a new virus, as in this case, we've never been seen before in the human population, therefore nobody's been exposed and nobody has immunity to it. The second criteria is you need increased morbidity and mortality around this disease. If it's a disease that you get infected with and doesn't make you ill, nobody cares, right? So in this situation, you have to have something that causes increased more than what's expected in terms of sickness and death. And then finally, the last criteria, and probably the most difficult one to achieve for many of these organisms, is sustained human-to-human transmission. There are many diseases out there right now, even, that have met these first two criteria, but never get to that third one, right? That you still need some animal exposure or some environmental exposure in order to get sick. Only if you get that third criteria can it become a pandemic. And that's what we're in right now. When we actually get to a pandemic, it results in expanded public health response, certainly social and economic disruption, which we've seen to great extent with this pandemic, and increased pressure on public health and healthcare communities, which we've also seen. So we first heard about this on December 31st, actually, of 2019 is when we were the world was kind of first made aware. And then WHO put out a publication on January 5th saying 44 patients in Wuhan, city in China, had developed pneumonia. Many were patients or operating dealers of vendors in the seafood market. So there's a key point in this, though, is that there was no evidence of significant human-to-human transmission. So what does that mean? It's, if you got human-to-human transmission, isn't it always significant? And the answer is no. It's because there are many diseases out there that have human-to-human transmission, but only have one generation. In other words, I get infected, I may be able to infect my wife, but she's not able to infect anyone else, right? So we don't have that sustained human-to-human transmission. We have some human-to-human transmission, but it's limited to one, maybe two generations at most. And that's what they're indicating here. So today actually is the 1-year anniversary of when the first case of coronavirus was confirmed here in the US in Washington State. And that person was a person that had traveled from Wuhan to the US. At this time, we had no testing in the US, right? I would venture to guess, and I know there's a lot of research being done right now looking at genetic sequencing, is that this virus was here long before that. I could probably say that probably back in December, we had cases of this in the US unknown, right? It was probably a very mild form of the disease, maybe something that gave you cold-like symptoms or maybe even influenza-like symptoms. This would have been during influenza season, so it may have been masked, and we wouldn't have tested for it anyway. By the 22nd, China issued another statement saying that there is now evidence of human-to-human transmission. So really at this point, we reach a pandemic threshold. Now, a pandemic wouldn't be declared for another couple months. And the reason being is you have to be cautious. When you yell pandemic, it can really cause a social and economic disruption. So you have to be certain. It has to demonstrate that it's moving outside of the countries and that it's at a much larger scale than what we knew about at the time, even though we met the criteria for being a pandemic. On February 29th here in the US, this is when we really kind of set things in motion in the US, right? This is when we had the first death associated with this disease in Kirkland, Washington, and we began expansive testing. at that facility and found 27 of the 108 residents and 25 of the 180 staff have some symptoms of the disease. So we knew at that time the cat was out of the bag. We still didn't have a comprehensive testing strategy in the US at this point. And then finally on March 11th, the World Health Organization declared a pandemic. And the head of WHO said, deeply concerned about the levels of spread and severity, because he was indicating that this is spread much faster and farther than what we believe because of the lack of testing, and expressed concerns about the alarming levels of inaction. And as of this, you could see where we are today. As an epidemiologist, what do we do in an infectious disease pandemic? Well, one of the first things I looked at is what's the reproduction ratio, and this tells me how infectious this organism is, right? The reproduction ratio is basically a number that says, okay, if I have one case of the disease, how many more cases can I expect from that one case? In other words, how many more people am I more likely to transmit this to if I'm sick, right? Because we're all susceptible. Nobody's had this before. And in this case, it was 2 to 4. So let's say an average of 3 people. So for every one case, I can expect 3 more cases. So you could see how easily these numbers can grow very quickly. Now that sounds bad, except if when you look at something like measles. Now measles is one of the most infectious organisms on the planet. It's got a reproduction ratio of 12 to 18, which means for every one case of measles in a susceptible population, people that aren't vaccinated or never had the disease, I can expect between 12 and 18 more cases. That's how infectious measles is as compared to coronavirus. But our goal is to get that reproduction ratio down to below 1. So for every one case, if they don't infect at least one other person, the pandemic comes to an end. Right now in Indiana, we're hovering around 1 to 1.5 reproduction ratio. So that number has come down quite a bit. It spiked a little bit back in October, November, December, and now it's starting to retreat again. But we're still hoping to get to that goal of being below 1. On March 16th of last year, the London College, Imperial College of London, actually came out with this article. And it's a overly complicated title for a journal article, but that's what we do. We overly complicate things, right? So this says impact of non-pharmaceutical interventions to reduce COVID mortality and healthcare demand. What they're saying is, what can public health do to slow this disease, right? We don't have a vaccine at this time. We don't have any clinical treatment. It's not like we have drugs that we could treat you with that will help. So what can be done to slow this down? And they actually published a list of things that they modeled or predicted you could do. And this is overly complicated and really small, but what this is saying is, well, let's isolate people at home. That will slow things down. Let's have people that are exposed stay in quarantine for 14 days. That'll slow things down. Let's physically distance or social distance for those over 70 years of age. Let's have the entire population socially distance. And let's close schools and universities. So what they were trying to model is saying, well, if I do each one of these things, how much percent or what percent can I reduce mortality and hospitalizations? And you can see out here on the far right, if we do all those things, depending on what the reproduction ratio, we can reduce hospitalizations maybe by 80% in some instances, and deaths by 30% in some instances. So that was really interesting. They wanted, here's a way we can model what the disease is going to do. And many hospitals then approached the school and said, what can we expect in Indiana? Because at this time, we had some personal protective equipment, masks and gloves and gowns and things like that, but we didn't have enough. So they wanted us to model what the impact is going to look like in Indiana. So that's what we did. We built a epidemiological model trying to predict what's going to happen. And we built it for a 12-week period starting in late March, going for 12 weeks into the summer. And we knew that somewhere around week 6 or 7, we were going to see about 3,400 new cases per day in the state of Indiana. And that sounds bad, but you have to remember, this was at a time when we were maybe seeing a couple hundred cases per day only, right? So to go to 3,400, overwhelm the hospitals. So we had to come up with a strategy to put this in place. And this is what we said. You know, if you remember back in April and May, we said we're going to bend the curve, right? We wanted to bend the curve. What they were talking about is the epidemic curve, and that's what the red bars here represent. So this is what our model is predicting. We could see by week 7 and 8, we're going to hit that peak. And we said, well, let's keep that from occurring by having people stay home, having people wear masks. Let's shut everything down and see if that works. Again, this is overly complicated graph, but this is the red bars represent what we predicted is going to happen. The line of, excuse me, let me step back. The red bars represent what we predict is going to happen to the hospitals, how many hospitalized patients are there going to be. The dotted line above the red line are the number of cases in the state. So as the cases go up, the hospitalizations go up, right? Now, the yellow and gray line are actually what really happened at the hospital. So our model is predicting this. Then we said, well, how many people are actually showing up at the hospitals? And you'll notice that we tracked pretty well up until about week 5, right? When we were about ready to start reaching into our peak. And this is what we did. We stayed home. By shutting everything down, the number of hospitalizations by the gray and yellow line here actually started to decline. Our model no longer fit because people were doing the things we'd asked them to do, wearing masks, staying home, washing, you know, your hands. It actually worked. So these public health measures, these things that we said you can do to prevent disease actually worked and continued to work, which is great news. Our state, I'm happy to say, our School of Public Health, coupled with the Governor's Office and the Indiana State Department of Health, actually conducted the first and still only prevalence study in the state of Indiana. And what this means is we want to know how much disease actually existed out there. And we learned a lot of things from this study. We recruited about 20,000 volunteers across the state to get tested. Not only, you know, the nose swab test, which says you have active disease, but we also took blood tests because we wanted to see how many people had antibodies, those meaning that they had been infected in the past. And so we were able to pull this off, and like I said, we're still the only state that's been able to do this. And one thing that we learned quickly, was really kind of disturbing, is that 40% of our population that we had tested had disease and had no signs or symptoms, right? Which makes this disease really hard to get our arms around. It's easy if people are sick, right? We know you're sick. We could isolate you very quickly. It's much more difficult to control a disease in which people are sick, they're infected and infectious. They're able to spread the disease, yet they themselves feel fine, right? When you feel fine, you don't seek out testing, you don't stay home, right? You're out and about and spreading disease, which is what made this disease really complicated in trying to slow down. The good news is we have a vaccine now, right? This is really an amazing thing. I know many people are worried about the vaccine because of the time at which it took to create this. It seems really short, and it is, but there is new technology that was applied to this vaccine. Now, this technology existed for many, many years, but it was never applied to, could we do this with a vaccine? And turns out we can. The second thing that occurred to create this vaccine is that these clinical trials that we always go through when we have a new drug or a vaccine, they kind of overlapped, and we've never done that before either, where we do phase 1 clinical trial, we'd stop, we'd analyze the data, and then we'd start phase 2, stop, analyze the data, start phase 3, right, with larger groups of the population. But in this instance, what if we started phase 1 clinical trial, and before that was done, let's start phase 2. And then before that's done, let's start phase 3. So we could kind of run them concurrently so that we don't waste a lot of time in between trying to recruit. And that worked out really, really well for us. So in that instance, no steps were ever skipped in creating this vaccine. The other thing that I really want people to understand is that research is still going on about this vaccine. We're actually in what we call phase 4 clinical trials, where once they're released to the general public, we still monitor for adverse effects or adverse events in the population, so that if there is a problem with the vaccine, we're aware of it right away, and we can put out messaging around that, like whether it's a allergic reaction or any other, like pain at the injection site. We can monitor those things. So that information is still being collected and monitored as we speak. And we really want to get to what's known as herd immunity. I know a lot of you probably have heard this term before, but basically what that means is we surround the most vulnerable in the herd with people that are protected. In other words, so the disease can't get to the most vulnerable. And one of the best ways to do that is to get vaccinated. And some of the early estimates say, well, we have to vaccinate about 70% of our population in order to get to herd immunity, which is a big number. But the good news is, and I've been monitoring some worldwide studies, and there's recent study just this week that came out of Israel. And they've been fortunate enough to vaccinate 25% of their population already against this. Now their population is 9.1 million compared to the 300 plus million we have in the US. But the good news is when they got to that 25% threshold, they started to see a downturn in cases. That's great news. The other thing that we looked at and has really been, and hopefully this is accurate, is that we were worried, could people that are vaccinated still spread the disease? And the data coming out of Israel says, no, there is no evidence of that, right? So that is really, really good news for us. So if I said, well, 25% of Indiana's population, we'd need to vaccinate both doses, 1.6 million people. So we have a little ways to go to get to that threshold. This is from actually this week. This is data that I put together to say how many cases per capita in Indiana. So how many cases per 100,000 in the state of Indiana. So this is back from February, you could see, all the way through this week. You could see that increase in cases beginning around the end of October through the holiday season, and now we're starting to decline again. This is really good news. Same with our mortality. So this is deaths in Indiana per 100,000 from March, and you could see that, and this is just a product of the number of cases. The more cases we have, the more hospitalizations we're going to have, and unfortunately then the higher mortality we're going to have. And just as those cases began to increase, so did the mortality. We leveled off here in late November, December, and now we're actually starting to see a real decline in mortality, which is good news for us. I looked at other states around us. I wanted to know, how did we compare to our surrounding neighbors? And we didn't fare very well, unfortunately, in the state of Indiana. I believe there's a couple reasons for this. So Indiana is in this kind of orange line. Michigan is the light blue, Illinois is the gray. This dark blue line represents all of the US, right? So this is the US average. And then we see Ohio and Kentucky down here in the yellow and green. So you can see that Indiana really jumped out in terms of mortality early, and we kept climbing. We led the nation for a long time in mortality before we started to decline. Michigan and Illinois are also starting to see those decline, but look at the US numbers. The US numbers as a whole are climbing. So the US as a whole is climbing. Indiana is starting to finally slow down a little bit. So why is this happening? Well, I think, as many of you are aware, not only age is a big risk factor for this disease, but so are other conditions, right? Those things like diabetes and obesity and smoking and other distressing situations on the body put you at greater risk for more severe disease. Indiana, we don't do well in health overall. We actually rank 41st out of 50 states, right? We definitely can do better without question. Things like smoking, infant mortality, obesity, lack of dentistry, cancer, physical inactivity, cardiovascular disease, all those things weigh on us as a population as a whole. And then you put a pandemic on top of that, it makes the situation that much worse. our public health funding, we rank 47th out of 50. In other words, we spend so much less than other states for public health efforts to reduce these things over here in yellow that you see. Now, I will commend the State Department of Health on their latest dashboard. If you haven't seen this, we've all seen the COVID dashboard, I believe. If you haven't, it's available. Now they have a vaccination dashboard because I want to know where we're at in terms of vaccination, right? I want to get to that 1.6 million. So this is as of January 18th, so a couple of days ago at 5 a.m., that 300,000 people in the state of Indiana have received at least one dose, and 63,000 are fully vaccinated in the state of Indiana. So we do have a ways to go in terms of that. I've heard many stories about people being hesitant to get the vaccine for various reasons. So I was really interested in what that looks like. So this is the number that intend to get vaccinated. So back in May, 76% of males said they were going to get vaccinated, and you could see that declined. 69% of women said they would get vaccinated, and it has declined. But since November, that number is starting to creep up. Race and ethnicity here is also very telling. The African-American community has been hit particularly hard by this. And this is coming from various reasons, right? We know that systemic racism has played a role in this. We know that access to care for that population has played a role in this. And history itself has made them vaccine hesitant. You know, when we look back at the Willowbrook Institute and the Tuskegee syphilis study, those are things that have played a role in their trust of Western medicine. So we need to do something to change that course because they are hit particularly hard by this disease, and their numbers of wanting to get vaccinated are still very low. Age, same thing, education, family income, all of these things play a role in people wanting to get vaccinated. Like I said, the good news is that we're starting to rebound. People wanting to get vaccinated is actually starting to increase, or intend to get vaccinated is actually starting to increase. When I look at some of the other data around this particular disease, 54% of US adults now know someone that's been hospitalized or has died, unfortunately, of this particular disease, right? So more than half of the US has known someone that's been affected by this, which is a drastic change from April and May, where you see about 15 to 20%. Percentage of adults who know someone who has died or hospitalized, that 54% for all. Look at the African-American population. They're at 71%. So you could clearly see that they know someone that has been affected by this. Those that are worried about getting the disease, look here again that African-American and Hispanic populations are more worried, as they should be, of getting this disease than other populations. So we need to change the narrative around that population. So when are we going to get back to normal? That's what everybody asks me all the time, right? When can I start to see my friends and family? And honestly, good projections right now are somewhere in the fall, late fall of 2021, I say. If vaccine rollout continues the way it should, we should be able to get back to normal. I have to look, though, at influenza vaccine. And last year, only about 46% of the population got vaccinated against influenza. Despite recommendations and risk of severe disease, fewer people took the influenza vaccine. So I think there were some lessons to learn from that. And what can we do differently to make sure that people want to get vaccinated and are able to get vaccinated? So I looked at, well, what has been done to change that narrative? So a few years ago, hospitals, nursing homes, they didn't require their staff to be vaccinated against influenza. And they quickly learned that if we vaccinate our staff against influenza, we could save many more lives. So what did they do? Well, the first thing they did was they made it free. Could we do the COVID vaccine? Absolutely. There should be no charge for COVID vaccine, and I don't believe there is. The second thing that we need to do, let's reduce the paperwork around this, right? Let's make it as easy as possible for people to get vaccinated, right? You don't need to bring all this information. You don't need to fill out a bunch of paperwork. We just need to get the vaccine in the arms. Third thing is we have to make it available to them. We have to bring it to them. Hospitals used to have a roaming cart of flu vaccines, right? They would just bring it up to your floor, and as you're moving in and out of rooms, they would vaccinate you, right? Made it as convenient as possible. So I think we need to do the same thing with COVID vaccine. Let's open up some of these sites. Let's make it as simple as possible, easy to get to, which will help implement or help bring about more people being vaccinated. Some additional lessons that we've learned is that we need clear recommendations. We need people we trust out there answering questions and making recommendations as to who and when needs to be vaccinated, right? Whether that's CDC, the providers, your public health officials, your federal government, we all need to be on the same page around this messaging. The second, we have to be positive with approach. We can't just dismiss people that question about the safety or efficacy of this vaccine. We have to be able to be patient and be able to answer their questions with them. Be proactive. Let's help people make appointments. Set reminders, right? So if you have friends and family that are eligible to get vaccine, help them out in doing that. And then get more of those people involved beyond the providers, right? Like having public health officials messaging and talking about this. All of those things I think will improve our vaccination, get us to where we all want to be, which is back together. So we have to get this right. The vaccine is not the savior we want it to be, unfortunately, right? A vaccine sitting in a freezer does nothing for anyone. So we have to be able to get the vaccine in the arm. And we know a percentage of the population simply won't take it. They don't maybe trust government, they don't trust the science, they just don't believe in vaccines at all. But we still need that population to at least be heard, understood, and answer their questions. We also know that we've seen the reemergence of some vaccine preventable diseases already occurring in the US and globally. So people are afraid to seek medical attention because they're afraid of going out because of COVID-19, right? So we've seen increased mortality around heart attacks and things like that because people simply aren't going to the doctor when they need to go to the doctor. The same is true of vaccine preventable diseases. We're anticipating a surge in measles and mumps cases, pertussis cases, because people aren't going to get vaccinated. Fear of traveling and going to the doctor. So we have to get this right. So with that, I will end and try and answer any questions you have around the vaccine or around the disease itself.
Well, thank you very much, Dr. Thomas. One of the questions I got in my chat was, will this COVID vaccine be similar to the flu in which we will need to get a shot every year? And what is the concern with COVID mutating into different strains?
Right. So let me tackle that first one of, will I need this every year? And the simple answer is we don't know yet. We haven't gone through a whole year of vaccines and the seasonality of this disease. We're coming upon that right now, and we're really not through the second wave of disease. Many pandemics have at least two waves, and we're kind of coming to the tail end of the second wave. It's going to still take some time to see how long the immunity from the vaccine lasts in the population and what this virus actually does. We've had other pandemics like SARS in the early 2000s that basically mutated itself out. We don't see it anymore, right? I was kind of hoping that was what's going to happen with this coronavirus, and we're not seeing signs of that yet. And remind me what the second part of that question was.
You answered those.
Oh, mutations. Yeah. So this is what viruses do. They mutate. This is why you need a flu vaccine every year, right? It's because of those mutations. Every time a human being is infected with this disease, there is an opportunity for a mutation to occur. Many of you probably heard about the UK mutation, which is more infectious, but doesn't appear to be causing any more severe disease. but you have to take that with a grain of salt. If it is more infectious, we can expect more cases. If we have more cases, we're going to have more hospitalizations. If we have more hospitalizations, we're going to have increased mortality again. So mutations are always part of viruses. Some mutate faster than others. There are several strains of this already circulating in the US. The UK strain is definitely one of them. We have every reason to believe, though, right now that the vaccine will still work on those strains.
Are there any studies showing side effects
from the vaccine? Or, yeah, there have been, yeah, so we did talk a little bit about phase 4 and monitoring for side effects. I think recently Moderna in California, there was a particular lot of the vaccine that was halted because they were studying someone that had a severe reaction from getting that vaccine. They've since restarted vaccinating with that particular lot, that there is no correlation between getting the vaccine and that reaction. So I know that, you know, severe like allergy, people with severe allergies, you definitely want to talk to your physician prior to getting vaccinated. But that's the only side effects other than the normal side effects like pain at the injection site, maybe some swelling, some tenderness, maybe a low-grade fever. Those are all signs that your immune system is working. Now, don't think that if you didn't get those after getting vaccinated, that your immune system isn't working. It's a little bit more quietly. Okay, so the good news is that when you have these low-grade fevers and things like that, that's part of your immune system responding to the vaccine itself.
And then we had someone who just got their second shingles vaccine. Should they wait a month between getting their next, between being vaccinated for COVID?
No, I don't believe there's any reason to wait. They may want to talk to their, they definitely want to talk to their doctor about this, but these are two different viruses and they work in two different ways. So there should be no reason not to get vaccinated after a shingle vaccine, but talk to your doctor first.
Now, for our viewers who weren't logged on the first couple minutes ahead of the 12 o'clock start time, our illustrious speaker today taught a class titled Zombie Apocalypse and Other Doomsday Infections. So when we look at how quickly this has spread around the world and captured the attention, how does this compare in your study going way back in time?
Yeah, so actually from 1918 to today, there have been 6 pandemics, right? Everybody thinks, oh, there's only that other one in 1918, and that's not true. Actually, maybe even more, because HIV is actually a pandemic. We don't think of it necessarily that way because it's not as infectious and not spread traditionally person to person like this disease is. So this looks a lot like an influenza pandemic. Like I said, it's behaving in some different ways in terms of who it's affecting and how it's affecting, because you know, some people escape with 0 symptoms whatsoever, while others have very severe disease, and just the range of symptoms of losing taste and smell and feeling lethargic and lack of motivation. These are some strange symptoms that we don't normally see with other viruses, but it's acting very much like the 1918-1919 influenza pandemic.
No, thank you. Are you advising the state on their rollout schedule of the vaccine? And we'll answer that one. I have another one right behind that.
Yeah, no, I'm not. I mean, we are consulting with the state on numbers. Like some of those tables and graphs I showed you are things that we produce weekly for the state, so that they get a sense of where we're at. But the vaccine distribution plan, I've not been involved in. I've reviewed their plan, I've looked at it, and I thought it was really well done. But it was written at a time when we didn't know when the vaccine was going to be approved or how much we were going to get. So there was no timeline in there. And I think I want people to really know that the plan was written, it was required from every state to be written for their particular state, and it's fluid. As the information changes, as more vaccine comes into the state, that plan can change and be updated to accommodate as many people to get vaccinated as possible.
And then were all healthcare workers given the opportunity to be vaccinated before the general population under 70? Is there any tie there?
Yeah, so I think there was at least a week or two that healthcare workers could sign up to get vaccinated. And I know many of them did. My wife being one of them, she's fully vaccinated now. And she's been working in the COVID clinics, vaccinating other people. And they're really working hard to make sure that they're not wasting any vaccine, that they will call on healthcare workers and make sure that people are signing up on the website. So it's a really important thing that when your eligibility comes available, take advantage of it right away.
And then did you have a mentor growing up that inspired you to pursue this study? I mean, way before it became fashionable.
Actually, it was 9/11 that got me into public health epidemiology. So I know many of you remember the events of 9/11, but after 9/11 came the anthrax attacks. And that's when public health really put out the call. I was working in public health at the time as an environmental specialist, had done many environmental investigations at that time about exposures and cause of disease. And so when those attacks came, CDC actually put grants into the state to build epidemiology capacity, because that's one thing that we lacked in the US was enough epidemiologists to respond to many of these situations. So they put out a call to hire and train epidemiologists. So I got involved in that, became a field epidemiologist, finished my education, worked at the State Department of Health for 12 years before coming to the university to teach.
What zombie movies do you think really get it right?
Yeah, that's, for teaching the class, I don't watch many of those movies because, the interesting thing about zombies and what a lot of people don't realize is the Hollywood zombie is a very recent phenomenon, not until the 1960s. But if you look at every culture around the world, there is some sort of ancient creature that these cultures use to explain natural phenomenon, right? In the absence of science and microscopes and germ theory, we use these creatures to explain disease transmission, right? So the one zombie movie that I watched that I think is fairly pretty accurate is the I Am Legend with Will Smith, was probably the most accurate in terms of science.
He actually worked about a block from where he lived in that movie in Washington Square Park. So it really was really awful to think about. The last question before we wrap it up and get you on to your leisurely afternoon of reading. How often do you think we'll be able to required to wear masks when we look at future travel procedures?
I would predict not, at least until fall of 2021, to be honest. We really need people to be vaccinated. And until we reach that herd threshold, wearing masks is still going to be the safest way to move about in the population.
Well, I appreciate your time very much. We will email you a certificate of appreciation. A donation will be made in your name to the Patachou Foundation.
Oh,
they address pervasive food insecurity in a radically different way.
Well, thank you so much. I really appreciate that.
You bet, certainly. Yeah, I support Patachou restaurants basically every week with Napoli's and Cafe Patachou up here in Keystone. Everybody, please reconnect with us next week on Zoom when our guest will be Georgianne Brown, a psychologist, COVID-19's effect on mental health, anxiety levels. Have a wonderful weekend, and we'll see you next week.
Thank you, everyone.
All right, thanks again.